Hola a todos, nos encontramos en el contexto del precongreso ICVA 2020 en esta experiencia virtual. En el día de hoy vamos a tener el honor de presentar al doctor Sorin Pislaru, con el cual vamos a conversar acerca del tratamiento percutáneo de la insuficiencia mitral. El doctor Sorin Pislaru es médico cardiólogo en la clínica Mayo en Rochester, Minnesota. Es jefe de investigación de la división de ultrasonido del Departamento de Medicina Cardiovascular. Es miembro del Comité de Guías de la Sociedad Americana de Ecocardiografía y es jefe de investigación del Departamento de Cardiopatía Estructural del Departamento de Medicina Cardiovascular. Hola Sorin, es un gusto y un placer entrevistarte en el día de hoy. Vamos a charlar unos segundos acerca de la insuficiencia mitral y su tratamiento percutáneo.
Thank you, Martin. It's a pleasure to be here with you guys, even from a distance. Always love to work with friends from the Cardiovascular Institute of Buenos Aires. So, Martin, I think a couple of things. We'll show a case to illustrate everything that we need to talk about. But I think in general, once you have severe mitral regurgitation that is secondary to an organic mechanism, that is not going away anywhere unless you do something about that. So you need to think either surgery or intervention if the patient is symptomatic for sure. And really the surgical risk and the repairability of the valve are the ones that dictate where you go. Are you going to do a clip? Are you going to do surgery? So if you want to look at this case, this is one of the first clips we did at the Mayo Clinic. He's 94-year-old guy, and he's a stout farmer. He takes care of his wife. He had no significant disease other than some hypertension in the past. And what he comes for is really acute pulmonary edema. He's in extreme condition, very out of breath. And he went into renal failure acutely. So his baseline creatinine has increased to 2.7 milligram per deciliter. So that's significant. And if you look at the transesophageal echo that he has, this is massive mitral valve regurgitation. Now, we use the tools, the STS risk score, and his mortality risk was about 18%. So there's no really good option for this very elderly gentleman. And you would say maybe you shouldn't operate, but he said he was gardening until last week. His wife has dementia, Alzheimer, and he needs to take care of her. So he's the primary caregiver for her. So if you don't help him, you're going to hurt two elderly patients. And his dad lived to be 107 years old, and he wants to beat his record. So that's important, you know. Now, if you look at one paper to look at how to evaluate the patient for suitability of the mitral valve, this is the one paper that you should remember. And really, you want to look at various elements. You want to see whether involvement is in the middle or scallops, or it involves the commissures. You want to see if there's calcification at the target zone. You want to know the mitral valve area, mitral valve gradient, the flail width, flail gap. So you have all of them there. And obviously, to the left is the more favorable position, and to the right is the more unfavorable position. And let's look at what our guy had. So this is the left ventricular view on the left, the left atrial view on the left, and right left ventricular view on the right. And what you can see, it's clear-cut flail. Now, what we do not see in this view, there's not a lot of calcium in the annulus. So this is good potential. Very important, there's not a lot of calcium in the leaflet itself. So this is clippable. It's a fairly wide jet, but we decided to go ahead anyway because there's no real solution. So Martin, do you want to go through what we look for when we guide this, or do you want to stop and ask another question?
That is one of the questions, is how do you guide, or how do you assess feasibility on this patient that you talking about that recently?
So I think that the feasibility would be related to those elements in the table. So we have another case coming, and I have more detailed 2D images of that particular patient, so you'll see more what I'm talking about. But important things to decide are: do you have it? Yes, no. Number two, do you have a suitable anatomy? Is there calcium at the target landing zone, yes or no? And obviously, you want to know that the patient is not a candidate for surgery, because if you can do surgery, that's what you should do. So in this patient, we decided he's not a surgical candidate because of the age. And what we do here, we are imaging the septum. So we are in the bicaval view on the left panel, and we put in an orthogonal plane so we can follow the transeptal puncture. And once they go into the left atrium, they'll advance this very, very thick steerable sheath for deployment of the mitral clip. And it's important for us to tell them exactly how much it's on the side of the left atrium, so they have enough space above. The next, they are going to come down with the clip. This is a tricky part. And the tricky part is because on the fluoroscopy, the interventionist does not know where the atrium begins and where the atrium ends. So it's up to the imager to tell them you're poking at the left atrial appendage like they're doing right here, or you're in the dome of the left atrium. So that's a very, very critical step. So guide them safely so they steer down the device into the mitral valve. And what you can see here, they did steer down. And if you look here, you have the orientation of the clip. So you need to make sure that they are in the correct position in the valve, just where the flail is, right here. And they're perpendicular on the valve leaflet. So when they try to anchor the device, it's going to be dead center. Now, in this patient, what we did, we ended up putting 2 clips, and this is the result. You want to make sure that you have the clips in stable position, and they are. You transform the single mitral orifice to a double orifice mitral valve, and there's not a lot of regurgitation left. There's some. But most importantly, we always record the hemodynamics of this patient, and this is how the left atrial pressure looks like before and after we did the clip. And patient actually went from being hypotensive, requiring pressors before the clip, to hypertensive, requiring vasodilation immediately after the clip. And his cardiac output increased by about 60% right away. So this was huge for the patient. And it just so happens that I saw him a couple of years later, and he's taking care of his wife. He's still on track to beat his dad at 107 years old. So that's the first case, the case of the organic mitral regurgitation.
Organic, yes. Do you think in functional mitral regurgitation, the clip still have a role? If it does, in which patient?
I think the clip in functional mitral regurgitation is really emerging use of this technology, and there's this recent controversy about whether you should or shouldn't do it, depending on which clinical trial you look at. You look at the mitral FR or COAPT, and we can talk about that later, or unless you want to show the slide now, or
show the case first, and then we'll
okay.
discuss about it.
So this is an extreme case. So I'll tell you up front that this has been a lot of discussion about this case. We just did this about 3 weeks ago, because this is as extreme as you get in terms of intervention. So this is a 51-year-old gentleman who has non-compaction cardiomyopathy, who has class 4 dyspnea. So anything that he does will cause dyspnea, anything short of being in bed. And he has been admitted to the hospital 17 times in 2 years. And he's on everything that the guidelines would say he should be on metoprolol, on sacubitril valsartan, on spironolactone, on torsemide. And his ejection fraction, despite all these, is extremely low. It's 20%. And what we see every time he comes into the hospital, he has severe mitral and tricuspid regurgitation. His diaries aggressively. And out of those 17 hospitalization, couple, 3 times we actually did the echo. And after you diurese him very, very aggressive, the mitral regurgitation goes away to moderate, only to come back later on. Now, this kind of patient would never be a candidate for surgery, ever, because the ejection fraction is so extremely low that probably patient cannot separate from the bypass machine, so you cannot operate on him. He would be a transplant candidate, except he's smoker, and because of that, he's not going to qualify for that. He would be a candidate for left ventricular assist device, except he does not keep his appointments, so because of that, he's not going to go for one. So you're left with nothing for this young 51-year-old. So this is how his tricuspid regurgitation looks like. So mitral regurgitation looks like. So it's severe mitral regurgitation. And this is really key to me when I assess a patient for suitability of the valve. This bicaval view, this biplane view, where you have the intercommissural view here. So you're at about 60 degrees. So you will go commissure to commissure. And orthogonal, you have the long axis view of the valve. So what you're going to do, you're going to grab this plane and slowly scan through the valve, pan through the valve, so you can see at all levels whether the regurgitation is present, yes or no. And number two, you can clearly see the leaflets here, and you can appreciate here I have regurgitation. Leaflet anatomy looks suitable for clipping. It's long enough, there's no calcium in there. And this is how you physically do the guidance. So we do the same. We want to make sure that they are grasping the two leaflets, and we display also in biplane, so we know that we are addressing only one of the jets in this particular patient. So the interventionist went on and clipped, and you can still see some residual mitral regurgitation around the first clip that they put in. And the more you look, the more you see. It's very, very eccentric. It has a quanta effect. So we decided to go for a second clip. So this is now the second clip in the grasping view. And you can see that we are directing it into the other jet that wasn't addressed. And this is really the result. So again, the double orifice mitral valve, there's not that much inflow stenosis. Look what happens with the left atrium. So there's now stasis really swirling with spontaneous contrast, because there's no mitral regurgitation to move the volume in the severely enlarged left atrium. And more importantly, look at the hemodynamics of this patient. So pre-clip, we were afraid of this patient. So we did the right heart catheterization at the same time as we did the clipping and kept the pulmonary artery catheter in place. So as you can see, he has pulsus alternance. So he goes up, down. And this is while he's on pressor support. He's on what the anesthesiologist calls rocket fuels. He was on norepinephrine and he was on vasopressin at really high doses. And then look post-clip. So the blood pressure increases. He no longer has pulsus alternance. Look what happens with his left atrial pressure. So LA pressure goes down substantially. Pulmonary artery pressure also decreases. So we will see how this patient does in the long run, but I have good hope that even in such an extreme case, clipping functional mitral regurgitation may help. All right.
Do you think it's a safe procedure, or about the complications?
So the risk associated with the procedure is fairly low. We quote a 1% risk of major event happening, meaning death, heart attack, or stroke. Dislodgement of the clip is very unusual. Usually we inspect very, very carefully before. Even if the clip dislodges, it hardly ever dislodges off the two leaflets. So if it were to lose it usually loses one of the leaflets. And what you can do in this case, you put a second clip right next to it, and then you secure the first one in that way. So fairly safe procedure.
Okay, so let's go to talk about these two trials with opposite results: the COAP trial and the mitral FR trial. What do you think? How is possible that?
Well, so I think people try to compare things that are uncomparable, really, and there's been a lot of discussion that maybe there was more mitral regurgitation by quantitative measures in the COAPT trial than in a mitral FR trial. There's a lot of discussion about proportionate and disproportionate mitral regurgitation in these two trials. But the question I always had about these trials was, where do we derive our data about guideline medical therapy in these patients? So I think the huge difference between the two trials was how very aggressive was the COAPT trial in putting every patient who's recruited through the heart failure clinic. So you had to be treated at maximum titrated doses of heart failure medication. You had to receive a CRT device if you had an indication for one. You had to be seen by a cardiac surgeon and by a heart failure specialist before you can be even randomized to have it or not have it. So this is in contrast with the MITRA-FR trial, where all these were recommended, but were not implemented before randomization. So you got randomized to medical therapy or no medical therapy, and then you went on with your treatment or not. So look what happens in our own heart failure clinic, because that's an interesting exercise. So we looked at about 1,000 patients who have heart failure with reduced ejection fraction. Everybody who has an EF less than 50%, who has been referred to the heart failure clinic for treatment. And about 40% of those have severe mitral regurgitation, and about 60% have only moderate mitral regurgitation. Now, if you treat them, the ones who have severe regurgitation, good news is that about 2/3 of them respond to therapy. So that means that these 2/3 of the patient actually probably do not need a clip, because if you treat them with medical therapy, MR goes away, you're home free, as long as the MR remains stable. Look what happens with the other guys. So about 60% who did not have severe MR, a fraction of them, about 10% of them, actually do develop severe MR. So the difference in the two trials to me is that if you go the COAPT route, you treat only these patients, these ones here and these ones here. So the ones who have true severe persistent MR despite your maximal therapy. So really the net effect at the end of medical therapy, you still have about 1/5 of the patient having severe MR. And those are the ones who probably you should treat. You probably shouldn't treat the other ones. So to me, that's really the gist of that. So if you treat MR with the medication, 2/3 of the patients improve, but you're still left with about 1/5 of the patient needing some sort of intervention on mitral valve. So I think that's what explains the difference between the two trials.
Seems like the clip have a role in the functional mitral regurgitation, but in very select patients.
I think you need to be careful with your selection. I think if you have significant MR that you quantitate, it's not just an eyeball test. I think it's moderate or severe by color, but you actually quantitate that, you measure, you have a regurgitant volume, an effective regurgitant orifice that are 45 cc's or more, and you treated them already and they don't improve. I think there's no really downside of trying the clip, because I think you probably are going to reproduce the COAPT trial results.
Thank you very much, Sorin. It was a pleasure. It was a pleasure for me share this few minutes. Thank you very much.
Thank you for the invitation, Martin. It's always a pleasure.
Entonces, como conclusiones de esta entrevista, podemos decir que la insuficiencia mitral es un problema que incrementa con la edad, empeora la sobrevida y tiene un gran nivel de subtratamiento. La reparación percutánea con sistema de Mitral Clip está indicado en pacientes con riesgo quirúrgico alto o inoperables, sintomáticos a pesar de un tratamiento médico óptimo, con factibilidad anatómica y descartados por un HERT-team para un procedimiento quirúrgico. La ecocardiografía transesofágica 2D y 3D tienen un rol fundamental en la valoración de la factibilidad y la guía del procedimiento. Y en los pacientes con insuficiencia mitral funcional, la selección del paciente es un poco más trabajosa, entendiendo el rol de la recaptación mitral, la función y la dilatación ventricular, que esté cumpliendo un tratamiento óptimo y de esta manera poder reproducir los mejores resultados del COAPT trial.